Confirming people online can hear us. Oh. Yes.
Audio okay now?
Okay, perfect. Yeah.
Okay,
Yeah.
all right, thank you. Thank you for that really kind introduction, Josiah. And thank you really for the invitation, Anna and Sama and to the whole center and collaborative. It's really a pleasure of mine to be here. I have admired a lot of the work coming out of Drexel, a lot of the neighborhood and the really growing body of research on climate and health. So it's an exciting opportunity for me to be here. It's also local for me, so that's always nice. And just get to interact with all of you and talk a little bit about my work and talk about maybe some intersections. So I'll just get started. I had something in mind when I was invited to give this talk, and of course the last 2 months have made me reflect on a lot of things, like I'm sure everyone is reflecting on. So I've tried to, the talk has not changed entirely, but I've tried to kind of weave in some thoughts about what it means to be doing this work in this context, and maybe what are some things that I'm thinking about in terms of areas of focus that I think hopefully will allow us to continue to move, keep moving forward with this work. Some things that I think are important to highlight. So would love to see what you think about that as well, and feel free to interrupt or hopefully we'll have some little time at the end. Okay, so with that in mind, I wanted to just start off by framing the conversation around some of these things I'm going to highlight throughout the talk, which are, I think one is just that there's been a lot of work happening at the local level when it comes to climate change and when it comes to climate change and health. And this has been the case for a long time. I've been focused on this area for over a decade now, and certainly this is not the first time. I mean, this time is clearly different, but this is not the first time that the federal government hasn't been interested in this area of research. But what we do know is that states and local municipalities, they're doing the work because they have to, right? This climate change is already affecting many communities across the country and around the world. And so I think thinking about how we can work with those local partners to really move the work forward and assist them in the decisions they're making is really important. I think connecting the dots between climate change and health and larger systems and structures that are relevant to all kinds of public health impacts and outcomes is really important, and I think a way that we can, perhaps get at some of the gaps, the things we haven't thought about, but also, to sort of think about this work from a broader perspective. Considering implementation, I think this is an area, again, action is happening at many levels, and sometimes it's informed by data and evidence, and sometimes it isn't. So where can we plug in to think about, what kinds of policies are happening? What kinds of adaptive measures are taking place that we can maybe be helpful in sort of thinking about barriers, unintended consequences, or uncertainties that we can help put some data around. And then finally, just kind of overarching thought of just always thinking about translation. So what do we want to come out of our work? And I think it's really critical to kind of be thinking about that from the beginning. So thinking about who are the community groups that you should be engaging with from the get-go? Who are the policymakers? Because those things can help inform the questions you're asking, and can also, I think, help your work to have more of an impact. And again, I think that's, now more than ever before, thinking about how to frame things in a way that makes sense for people to be able to use, and for this work to get done. Okay, so now, broadly, I think that climate and health research really, there's kind of 3 broad buckets of ways that it can inform policy and practice. So the first is just characterizing the burden of climate-related stressors and their public health impacts. And this is, I think, the area of work that probably we've done the most in, you know, what is the public health impact of heat, of extreme weather, of all kinds of different climate related stressors. Not that there isn't still work to do there, but we've made a lot of progress in that area. There's also thinking about, you know, drivers of vulnerability, and how we can use that kind of data and that kind of research to target resources more effectively. So to understanding, you know, who are the subpopulations, who are the communities most impacted, and how can we use our science and evidence to inform policies that, you know, efficiently and effectively can help those communities. And then finally, I think probably the area where the most work still needs to be done is thinking about solutions and thinking about, you know, this is thinking about climate mitigation and adaptation solutions, but really, what are the public health impacts of these solutions? And so are these solutions that communities are putting in place, are they having any effect on the public health? Are they lessening the public health burden of heat? You know, or are they helping people, you know, cope better after disasters? So I think there's still a lot of work to be done there. It's an area I'm very interested in. I'm going to talk a little bit more broadly about the solution space and really talking about not necessarily evaluations, but thinking about implementation of solutions and what are some barriers that come up, what are some potential unintended consequences, because I think this implementation space is also, you know, really in need of better data. Okay, so let me start with talking about characterizing burden. And first I wanted to say that, you know, as I said, we've really seen a tremendous growth in the literature around climate change and health. So this graph that I'm showing here is from a review paper that looked broadly at climate change and health literature over time. And what you can see is that, you know, there was work in this area going back to the early 90s. But we really started to see an increase in the climate change and health literature, you know, around the mid 2000s. And then I would say over the last 10 years, there's been a real exponential explosion of literature in this space. This, you know, is due to a number of factors: growing awareness and interest, also growing funding opportunities in this area. But I would say a lot of this work has really focused on characterizing that burden. You know, so what climate related exposures, what kind of public health impacts do they have, quantifying that burden, and really understanding it. And within that kind of that literature, if you break that down by hazards, and the graph on the right is actually limited to literature just in North America, but I think it is representative worldwide. Most of that literature, or not most of it, but the largest portion of that literature has been devoted to heat. And there are a lot of reasons for that. You know, we know, for example, in the US, heat is the type of weather event that is associated with more mortality than any other type of extreme weather event. We also knew, you know, from sort of the research and data analysis perspective, it's easier to get data on heat and relate that to health impacts than some other types of events and things. So we've seen a lot of work on heat. I'm actually gonna, you know, a lot of the examples of the work I'm gonna show from my own work is based on heat. It's an area that I've studied a lot. And within that, what you can see in that bar, the sort of dark blue, is really just, you know, around thinking about the impact of heat. So the majority of this literature has focused on, again, characterizing the burden of heat on public health. So if we talk about that, what kinds of studies have we seen? Well, this is an example of a study, a really nice study that was done from the Multi-City, Multi-Country Collaborative, a group that looks at, you know, heat and other climate-related exposures worldwide. And the nice thing they did in this paper was they not only looked at that relationship between heat and mortality over time. I think they looked at about a 3-decade period. But they went kind of the extra step and they said, okay, you know, we see this clear relationship, but we also can say that because of the way that climate change has affected temperatures, and you can see, That's shown in this graph, right? So this is sort of this is the graph of annual average temperature on the y-axis over time on the x-axis. This orange line is what the temperature trend would have been if we weren't subject to anthropogenic climate change. And this, I guess, purple color is, what we actually experienced due to anthropogenic climate change. So then they related back that mortality burden to that differential. And they were able to conclude that, I think it was about 40% of the heat-related mortality we've seen in these different cities around the world was over this about 3-decade period was really due to that anthropogenic change. So it was a nice kind of merging of the exposure response epidemiology work with climate science attribution, which I think was really nice, and hopefully we'll see more of that. Coming a little more local, these are from referencing a couple of studies that were conducted in the US. And this is generally to get at sort of, we know that, heat is a large, in terms of weather-related events. It has significant impacts on health. As I said, it is really the weather-related event responsible for the most mortality in the US. But what is that number really? Because we know that we see a lot of excess deaths when heat waves occur. They're not always easy to identify from a death certificate, right? They're not coded as due to the heat. So these are a couple of examples of national studies that have tried to put a number around that. The numbers vary depending on the study, but it's in the thousands, it's maybe in the tens of thousands. And these are, one of the first study is a little bit older, so, probably closer to that sort of tens of thousands range. Definitely larger than what's reported from those direct heat mortality events. So that's, I think there's been a lot of work in that area, a lot of multi-city studies. Where I think it's sort of important to think about is what is that local public health burden? And again, we can, so we can kind of run those analysis locally. You can do it, I'm sure you have done it in Philadelphia. We can think about, I know that work has been done in New York City. And what can we learn from that? That can inform local on the ground policy. So I think the thing to know is that, there are actions that are happening. There are preparedness actions that are happening locally to protect people from heat when an expected heat wave is about to occur. Typically, communities use alerts that are based on a National Weather Service regional threshold. And once those alerts happen, once the forecasted temperature is expected or the heat index is expected to reach a certain threshold, those alerts may happen, and that may trigger additional actions. Opening of cooling centers, heat response plans. But there's been some work that has looked at these alerts and their activation, and does that have any effect on preventing mortality in heat waves? And the limited amount of studies that have looked at this have shown not really in the US communities that they've looked at. Okay, so it's perhaps not effective, and the question is why? And I think the folks that were doing some of that work proposed there could be a couple of things. One, lots of different things happen in different communities when these alerts are triggered, and so they weren't accounting for the different types of actions that were happening. The other thing, and there was a nice paper that came out of CDC that looked sort of broadly to show that we start to see health impacts. We start to see people going to the hospital at thresholds, so temperatures or heat indices that are much lower than what those alert thresholds are being triggered at. So maybe the threshold is incorrect. And in certain cases, some places, for example, New York City being one of them, have actually lowered their threshold in response to their epidemiologic investigation. So, this is something that I think is really important and can change local policy. So in thinking about, when I was starting some new work, where I might want to try to think about doing this, this is a graphic looking at 50 large US cities, and their characteristics of their heat wave characteristics. So the top left one is how frequently heat waves are occurring. the top right, the duration of the heat wave, so how long are heat waves occurring? The season, how long does the heat wave season last in the lower left, and then the intensity. So, you know, how much degrees increase are we seeing above a certain threshold in terms of heat waves? And this is over like the last, you know, from this period of 1961 to 2023, how that's been changing. And what I want to call to your attention is you see a lot of these cities have large dots. That means they're, you know, they're getting worse in all of these characteristics. They're on the high end of sort of how these characteristics of heat waves are changing. And if you can see in you know, Southeast Louisiana, New Orleans, we have large dots on 3 of these 4 characteristics. So in New Orleans, heat waves are getting worse in a lot of ways. We also know that in New Orleans, about a quarter of the population lives under the poverty threshold. So it is a particularly heat vulnerable place. We know it's climate vulnerable. We often think about hurricanes and tropical storms, but it is very heat vulnerable and conditions are getting worse there. So that sort of leads me to a study that I'm leading in partnership with several other institutions, including you know, Johns Hopkins, RAND, the Louisiana Department of Health, and an organization called IC Change, which is based in New Orleans, does a lot of work on sort of community engagement and using local community sourced science to kind of inform climate policies. And in this study, there's multiple components, but the first one is really to characterize the burden. So what I just talked about, sort of understanding what are the thresholds where people are starting to go to the hospital from heat. And in the second aim of this study, which I won't talk about today because we're just getting started with that, but we're also going to be looking at, again, in collaboration with the health department, when people go to the hospital, what neighborhoods are they coming from? Are there particular neighborhoods in New Orleans that are very heat vulnerable? And then finally, I will talk about a little later in the talk, we're working with IC Change to actually go into homes. We've done this already, and really recruit participants to understand their lived experience when it comes to heat. What are the conditions in the homes, and what are some of the more subtle health impacts that they're experiencing day to day from heat? So let me talk about that first aim in terms of characterizing burden. So just really briefly, in New Orleans, when I talked about these advisories and these alerts that are triggered at certain thresholds, this is from the New Orleans Emergency Management Department, NOAA Ready. And you can see that, if you can read it, their heat advisory is triggered at a heat index higher than 108 degrees Fahrenheit. So that's, you know, using humidity as well. Or a forecast, when a forecasted temperature is higher than 103 degrees for 1 to 2 days. And that's, you know, those are thresholds that are used generally in the South. And I don't think there's, you know, was any real local data that informed this. So we're looking at the hospitalization data, and this is from some work from one of my doctoral students, Polly Matthews. And so, you know, just some very basic modeling right now. She's looked at the relationship between temperature. She's looked at several different temperature metrics and all-cause hospitalizations using a distributed lag nonlinear model. Well, actually, this is I think from a linear, but the different lags. And we really see that, first of all, you know, it's really that same day, that day of the hospitalization that seems to have the most impact for this particular community. So that's one important piece of information where we're seeing that elevated risk for all-cause hospitalization. And then this is, you know, when she actually modeled temperature as a spline. And we see, again, you know, a small relative risk for all-cause hospitalizations across this range of temperature. But what I want to point out is that we're seeing that risk start to rise at, you know, under 90 degrees. So, you know, I think it was like around 87 or 88 in the data, but definitely lower than the alert threshold. So we're still, you know, she's still working on this as part of her dissertation. But certainly one of the things I think that will come out of this is that, you know, maybe that threshold, you know, could use some more thinking about. Okay, so hopefully, you know, that sort of emphasizing this opportunity to really inform local policy, and again, working with policymakers directly in the community. We're working with Louisiana Department of Health, but our advisory panel also includes someone from the New Orleans Health Department, to really, understand what's possible for them in terms of thinking about resources to change or not, in terms of how we kind of, make some recommendations from our conclusions. So now I want to talk a little bit about understanding drivers of vulnerability. As I said, we're going to be looking at this in the New Orleans study, but since that work is still ongoing, or we're just getting started with the vulnerability piece, I'm actually going to refer back to an earlier study that I conducted in New York City that I think is a good example and really is the framework that we'll be following in New Orleans. So we'll see if the results are similar. But this is a case study that I conducted quite a while ago in New York City to look at heat vulnerability. And the objective at the time really was to, this was a collaborative study with the New York City Department of Health. They had already really characterized they'd done that first step, characterizing the burden. So they knew that they were seeing mortality increase within the city when the heat index reached a threshold of about 95 degrees for about 2 days. That's when they would really sort of see a sharp rise in mortality. So when I started collaborating with them, we were interested then in saying, okay, well, what's the next step? We know that people are dying when you reach these thresholds. Who is most at risk of death? And are there particular neighborhoods that might be targeted for adaptation measures that potentially could be helped? So we decided to conduct a case-only study because, again, we were really just interested in that effect modification piece. So it's a nice, efficient study design. If you're not interested in the main association between an exposure and an outcome, but you're interested in, that third factor of who might be most vulnerable. And we used their temperature definition, or their threshold definition to define our heat wave days. So we used when the heat index was at 95 degrees Fahrenheit or greater for 2 consecutive days. We decided that those would be our heat wave exposure days. And then we looked to see what types of individual and neighborhood characteristics increased risk to die, of death during those days. And we found that there were a number of factors that increased risk, including some individual components. We found that non-Hispanic Black New Yorkers were more likely to die on heat wave days versus non-heat wave days during the warm season than any other race or ethnic group. People were more likely to die at home than in hospitals or institutions. And people living in certain neighborhoods were more likely to die on heat wave days versus non-heat wave days. Those are neighborhoods that were, more impoverished, and also neighborhoods that had higher surface temperatures and less vegetation, which obviously all correlate. So we took that evidence from the epidemiologic study and we decided to sort of map it across the city. We first created an index with those factors that came out from our epidemiologic evidence as statistically significant modifiers of that heat mortality relationship. And then we looked at their prevalence across the city. We combined them simply by creating Z-scores and adding them together to look and see, what were the areas where these factors that we had shown increased mortality risk during heat wave events. Where did they cluster together? Were there particular neighborhoods that we could identify as most heat vulnerable? And you can see from the map that we created, so the red areas were where you have a lot of these factors clustering together. This is areas like Upper Manhattan, the Bronx, Central Brooklyn. And those were relatively much more heat vulnerable than some other parts of the city. And I think, the thing to know about this map is it's not complicated methodologically. And I know many of you, do this very easily, but it became a very useful tool in translation. And so again, I think, sort of highlighting what, thinking about local work, thinking about what policymakers need, and how your work can be easily communicated and translated. I just last year was talking to someone that I worked with when I was working in New York, who was the assistant commissioner at the time, and we were kind of reflecting on this work. And I always laugh because I'm like, I mean, it was kind of we could have predicted the results, I'll say, right, before we did the study. And it wasn't the most methodologically challenging study. And I sort of think like, wow, I think that's this, I may never have work that's more impactful than this study was, because it has gotten a lot of traction. And what he said in response was that, I think that's why, because it was simple, it was easy to understand, it wasn't a very, complicated statistical modeling process that, couldn't be replicated again. So the Department of Health has continued to use this index and update it over time. And so sometimes, by chance or by luck, I think that worked out really well. But I think that it's important to remember that that translation piece is so critical in thinking about what an end user can use to kind of move policy. And so in terms of some of the impacts of this work, a couple of years after we published the results, the Department of Health was, able to take it. They took it to the mayor's office. It was highlighted as part of this, multi-million-dollar effort called Whole Neighborhoods NYC, and highlighted throughout this plan as being the basis for where a lot of this plan was implemented. So, one thing I highlighted here is that, this is talking about the tree plantings that were associated with this plan of, a huge $80 million effort to plant new street trees. And where were they targeted? They were targeted in the South Bronx, Northern Manhattan, and Central Brooklyn, because those areas were identified by the vulnerability index as disproportionately burdened. So, this was, I think, not only gratifying for me, but just important to kind of see that connection of how we can use data to inform policy. And again, to highlight the importance of local work and how the work, I think, will, have started long ago and will continue. I just wanted to note that there's a body called the New York City Panel on Climate Change that was first convened in around 2007, 2008. They work together every few years to produce a report. It's convened by the mayor's office, and it's an independent scientific body that synthesizes the evidence to help the city use the latest data and evidence to inform climate adaptation policy. Actually, the current iteration of the panel, which I'm fortunate enough to be on, is co-chaired by 3 individuals. One is your own Franco Montalto, who is not at the School of Public Health, but is, I think, in civil and environmental engineering. And so it's been great to work with him, but just also I wanted to point this out because, again, figuring out these bodies that, are doing the work and need the data and evidence is very important, I think, for thinking about our work over the next several years. And again, just to highlight that this is from the last report. I wasn't on the panel at the time, NBCC 4, but the panel continues to use the heat vulnerability index in their reports and to drive policy change. So that work has had a really lasting impact. So again, let's go local. Okay, so now I want to talk a little bit about, so I kind of hinted at some of the solutions, at least that New York City implemented. And I want to talk, now for the rest of the time, more broadly about the solution space, what we should be maybe thinking about when we're proposing sort of from the research angle, solutions on climate adaptation and mitigation and how they might impact health, or when we're working directly with community groups or policymakers, what we can potentially offer in that space. I think there is a lot of work to do in terms of, again, evaluating effectiveness of these types of solutions for their health impact. I'm going to talk a little bit, I would love to do that work. I haven't really had much in that space at this point, but I'm going to talk a little bit about sort of more broadly implementation of solutions, thinking about unintended consequences, and thinking about implementation barriers. Okay, so if, from that work in New York City, and from the wealth of literature that has been there, a lot of things that have been proposed when it comes to thinking about decreasing heat health burdens is thinking about green space, or thinking about improving communities, particularly communities that have historically been disinvested, and thinking about where are there areas of opportunity to kind of lessen those urban heat islands and build up green space. So when I was starting to think about this more, I was impressed with the work of this organization called Groundwork USA. I had seen a couple of presentations of work they had done, and Groundwork USA is an umbrella organization, but they have trusts that operate in small to medium-sized cities throughout the country, and where these trusts operate very locally, and their mission is kind of to work particularly in environmental justice communities that have been disinvested in, and really find ways to kind of improve those environmental conditions, improve public health. And they had a special initiative that was, I think, a pilot at the time. I think they've since expanded this to more communities, but that was focused in 6 cities called the Climate Safe Neighborhoods. And in this project work, they were thinking particularly about neighborhoods that were historically redlined, that maybe, were much more subject to the urban heat island effect than other parts of the city, and thinking about work they could do there to improve the local environment. And a lot of the work they were doing was advocating, or actually, working through sort of construction efforts of green space development and improvement. So what we wanted to do with our partnership with them was to understand, what were they specifically focused on? What kinds of solutions were they looking at? As I said, a lot of it was green space, and understand facilitators and barriers to the process of getting that work done in the solution space. And I won't have time to talk about all of what we learned from that work. We have a paper that was published in Environmental Justice on all of the interviews we did with both the Groundwork staff and the policymakers that they were interacting with in these 6, or actually I think we added 7 communities. But I wanted to highlight just one piece of this, because this is something that came up over and over in the interviews that we did with the Groundwork personnel, which was that they felt that their communities really were concerned about a lot of these green adaptation efforts. That they, people, you can read the quotes for yourself, but some of the community members felt like these improvements were really for them. They were going to be for the people that moved in after them, after they were displaced. And so there was this real kind of concern on the Groundwork folks' part, concern by their community members of, how are these improvements really going to affect them or help them or even hurt them? One thing we started to talk to them about was some of the sort of other things that they were thinking about when, as they had these conversations. So for some of the Groundwork members, they talked about, this means we have to think about other solutions. We have to think about community land trusts. We have to think about, kind of aspects of policies that go beyond our sort of initial focus of environmental improvements, because it really gets to issues around housing and renter rights and things of that nature. And this concept of green gentrification, or green space improvements triggering gentrification, it's not a new concept. It's been discussed in the literature. Want to shout out to some of Leah's work and collaborators here who looked at this a few years back. So there is some sort of building body of evidence that this may be happening. And other types of improvements in neighborhoods can also potentially trigger gentrification. I think it's not sort of a settled issue, and there are a lot of questions about how we even measure gentrification that I'll talk briefly about. But this is definitely, I think, a concern that we should be aware of, especially when a lot of our work is pointing to more greening, more greening. So, am I anti-green space, or does that mean like we shouldn't green neighborhoods? I I wouldn't say that, no, I very much appreciate green space myself. I think it is an improvement and there are a lot of benefits, to thinking about this, but I guess what I'm trying to show with this comic, or this figure, is that we really have to think more broadly. You know, we can't just think, particularly those of us focused on climate, we can't just think about, green space and that relationship with heat, and how that might help climate adaptation, because we're really, there's an interaction with larger systems and structures, right? And so, we don't want to be like this guy here, where we're sort of remedying one solution just to create a whole nother problem. We want to think holistically, what are the systems and structures, particularly when it comes to thinking about historical and present day discrimination, structural determinants of health, social determinants of health, housing. How does that sort of interact with our issues around climate and health, and the adaptation measures we're taking? I think we can, do that by really working in community with people that are most infected. We hear about these potential unintended consequences probably before we would have thought of them. And also thinking about sort of, when we're working with policymakers, understanding the landscape of what is within their purview. Are there other, sectors that we should be thinking about when we propose solutions? And so that's a piece of this sort of implementation, thinking about climate implementation and adaptation, is really thinking about, what are the unintended consequences. So what I want to kind of, probably focus the rest of the talk on is just, thinking in terms of climate vulnerability, how much are we thinking about these root causes? And this is work that was recently published also from the same doctoral student, Shefali Matthews, where we just kind of tried to understand, well, first of all, in the literature so far, when we talk about climate and health and we talk about vulnerable populations, how often are we talking about root causes? And so, this was a literature review. She focused on hurricanes just to use as a case study. But just really briefly, she looked at about 100 articles or more. Most of the ways of kind of measuring vulnerability, you can see were demographic. There are these, things like race, ethnicity, age. Then there was a good category of literature that really focused on spatial determinants. So, different neighborhoods, kind of like what we did in the New York City study. But if you go down the list, very few studies really focused on those upstream structural factors. So policies, maybe thinking about housing policy. Some of the other things she came across were sort of thinking about incarcerated populations, so the prison system, the education system. And she proposed in this paper to really try to tie our climate and health vulnerability studies more broadly to these upstream structural and social determinants of health. So we have the systems and structures of oppression, but then we, below that, we can really start to think about some of these broader policies that relate to housing, residential segregation, zoning, in other types of infrastructure. And she also has a list of, probably, it's not complete and it's probably, there are definitely limitations, but data sources in this paper that we might want to start considering to incorporate in our climate and health vulnerability studies. I want to focus more specifically on this piece related to, this infrastructure piece that I think is really so important when it comes to climate and health, which is the housing policy, residential segregation, all of these aspects that I think are sort of sometimes understudied within this space. And so this is a graphic kind of adapted from something many of you have probably seen before, but there's this concept of the 4 pathways that sort of connect housing and health. So I've added into the middle the climate piece, right? But this has been studied in the housing and health space for a long time. There are these 4 particular pathways where it's thought that housing may affect health outcomes. So I'll start at the bottom right, which is the neighborhood environment. So again, coming back to green spaces, walkability, things like that. I think in the climate and health space, we've done a very good job of bringing that in. You know, we have a lot of work that is looked at, so let's say heat and morbidity and mortality, and then interactions with green space. We propose that often as many of the solutions that we would like to see more. Then there is this piece on affordability and accessibility that covers things like residential segregation and gentrification. So again, we're, you know, I think starting to see more of this. We've seen a lot of papers on historical redlining and how that relates to climate exposures and how they're distributed throughout a city. We're starting to see more on gentrification, but there is some work to do there, I think. And then there is this piece on housing stability or housing insecurity. I think this is really an area of opportunity for those of us focused on climate and health to really start thinking about housing policies that relate to eviction or renter protections and how those things really can protect people when it comes to climate-related exposures and climate-related disasters. Some of this has been, you know, in terms of thinking about houselessness, it's harder to get that data on these populations. So I think that's a reason we haven't seen as much of this, but certainly on housing policy, I think we can do more in that space. And then finally, quality and safety. And this really gets to thinking about the conditions of the home, and in particular, the indoor environment. And I think this is also an area that, you know, we're starting to see more and more, but we could do a lot more in that space because it's often where people, you know, housing is sort of, can be the refuge, it can be the place of protection, and it can put you more at risk when it comes to a climate-related exposure. So I'll run through this really quickly because I want to save some time for questions. But in my group, we're doing a little bit of work in each of these areas. So I have another doctoral student who has been looking at redlining, historical redlining, and health outcomes after Hurricane Harvey. This is in, you know, combining that historical redlining data with data from the Texas Flood Registry. Her name is Rashida Callender. And this work is not published yet, but in progress. But essentially, she not only found that areas that were previously redlined had higher Hurricane Harvey exposures, so more flooding, but she also found a significant interaction between redlining and those Harvey-related exposures and their impact on certain health outcomes from immediately following Hurricane Harvey. So people were more likely to see, there was more likely to be an association between having your home damaged in Harvey and having shortness of breath or having problems concentrating if you lived in a previously redlined area than in other neighborhoods. This is from one of my other doctoral students, Erin Bennett, and she's really interested in diving more into gentrification. So I think, again, this is an area we can be thinking more about. This is just to show that depending on how you measure gentrification, you can get really different results. So she's compared two common methods used in the literature, the Freeman method and the Dean method. And I want to highlight the right panel, the Baltimore panel. On the left-hand side, you can see that we use the Freeman method to define which census tracts within Baltimore are gentrifying. And on the right-hand side, she used the Dean method, and she sees really different results. Less of a difference in Pittsburgh. So these are just two examples of cities she started to look at. So it really depends on the place, it depends on the measure. She's looked at different time periods, that can make a difference. And then in the work that we're actually continuing with groundwork, we're asking them their perspectives on gentrification. So then, you know, the subjective experience can completely differ from some of these objective measures. So I think there's still a lot of work to be done methodologically on how we measure this, incorporate it into our climate and health studies. In thinking about that housing insecurity, again, this is an area I'm very interested in. I know there's a lot of work here being done on housing, so I'm excited to talk to people more about this. But I'll just highlight that Leah and I have thought about this broadly, and we put out an op-ed last year about really sort of, you know, housing policy is climate policy. And so how can we better connect those dots and incorporate that into our epidemiologic work? And then lastly, I want to talk about that quality and safety pathway, and really focus on the indoor environment. So back to my study in New Orleans, you know, heat-related deaths, really, we've measured most often in our studies, we measure ambient and outdoor temperature, but heat-related deaths happen inside. That, you know, we know that from studies that have been able to go through the death records in more detail, people are dying in their homes. So, you know, I have some statistics here about New York City, direct heat deaths, about 85% of those decedents were exposed at home. In Louisiana, they've done some, you know, similar work to kind of look at this was just over a 1-year period, but a third of those deaths occurred in the home. And then even when we think about climate-related disasters like Hurricane Ida, we know that a lot of the deaths that happened, or at least the deaths that, you know, could immediately be identified, those were happening because people were trapped in their homes without adequate cooling. So communities are starting to recognize this and trying to take measures to protect people in their homes. There are a number of municipalities around the country who have implemented indoor residential cooling standards to protect people. So just like if you're a renter, your landlord has to make it possible for you to maintain heat in the winter. Now communities are starting to say you have to be able to maintain certain cool environments in the summer. And New Orleans is a city actually that just implemented a standard just last year, is part of a larger Healthy Homes program, which has a number of conditions for renters to protect them in their homes. But I'll highlight one, which is that landlords have to maintain an environment where the temperature in the bedroom does not exceed 80 degrees. And I think it's well, it doesn't say overnight, but it's meant to be, I think, an overnight because it's a bedroom temperature. But, you know, we don't, this is just enacted. We don't know how it's going to be enforced. And we also don't know, you know, what are the barriers to even implementing this? I mean, certainly there are landlords who you know are not reputable and you know really need this push of an enforcement action to protect their tenants. But there may be other situations where it's just not feasible given the conditions, or the conditions may be okay, but the tenant is not able to actually run their air conditioning because of other cost constraints, right? And so what does this actually mean for protection? So we didn't, as part of our New Orleans-based study that I mentioned earlier, we didn't design that study with this Healthy Home standard in mind. So this isn't an evaluation. The study was proposed, you know, before I even knew about the standard. But I felt like it's an opportunity to maybe try to make some connections because we were collecting data over the past 2 summers in 2 neighborhoods, 2 predominantly African-American neighborhoods and predominantly poorer communities in New Orleans. We're collecting temperature and humidity data inside their homes for about a 2-week period. And then we're asking them also lots of questions. So we do a whole intake survey where we ask them about, you know, questions about their home and demographic characteristics. We place a sensor in their bedroom for about 2 weeks. And then we also periodically, over a 2-week period, send them questions, really brief questions about their physical and health, subjective physical and health. I'm not going to talk about that. We're just starting to analyze all of this data now for the past 2 years. And I don't really have time to talk about that, but just, I want to mention just a little bit about the indoor temperature measurements. So this is our sample of participants. Again, it was a mostly African-American sample and pretty poor participant samples, you can see from the graphic on the right. One other thing to point out is that most of the residents had some form of air conditioning. Although it's, you know, it's the South and air conditioning is prevalent, but many of them are window units and many of them don't run their air conditioning all the time, even in hot weather. So we definitely see this distinction between the red bars the red plots indicating those people who reported they have a window unit and they don't run it all the time or most of the time, even during very hot weather. and the blue indicating participants who run their, who have central AC or may have a window unit but run it almost all of the time. And then this is, that same data, but modeled with a couple of other factors, some home characteristics, predicting what are those average indoor temperatures that we see based on the two strongest predictors were the outdoor temperature and the type of air conditioning that they have in the home. And so what you can see is, we see this big differential between those people in the blue that have those central ACs and running them all the time, and the red with those window units not able to run them all the time. So if we think about this in the context of that indoor cooling standard, which is at 80 degrees, right? And this on the y-axis is the indoor temperature overnight. So we specifically took the chunk of our data that was looking at overnight temperatures. So one thing we can see is, they set this at 80 degrees. And again, this is a very limited sample, not designed to test this, but we can kind of see that, maybe that 80-degree number is right. Like, it seems about right if we're starting to see health effects around 87, 88. Then for both of these populations, that may be a good protective number. Again, this is not a representative sample of indoor temperatures from New Orleans, so there are a lot of caveats to that. But the other, I think, more important thing to point out, is that a lot of the sample, and these are renters and homeowners, cannot maintain that 80-degree indoor threshold. And we don't have the data to know if that's because of the unit or because they just won't run it because they can't afford to run it all the time. We collected a little bit of information on their utility bills, which we're still going through. But I think that's a really important piece of data for implementation, right? First of all, it's not just renters that are at risk. Homeowners, and in our sample, may be more at risk because they have a lot of other things to keep up with. And also, what is the feasibility? If you're going to put a standard like this in place, well, really we have to think about the ongoing maintenance for the renters themselves and how they, what kinds of assistance they will need to kind of still maintain a safe temperature. And this is just going to get worse as time goes on because, we know that around 90 degrees outside, we're starting to see that wall of where you can't maintain below 80 inside. Well, we're going to see many more days surpassing 90 degrees, and this is particularly data from climate models for New Orleans. Okay, and then finally, just again, talking about translation, we have made it a priority in this study to really report back these results. We provided them, some written information. We've just held a community meeting in January to talk about these results. And I think that's, again, a way just to get more insight and more information to interpret our findings appropriately. Okay, so I'm out of time, and also I apologize because I wanted to have more time for discussion, but hopefully this highlights, I think, some of the things that hopefully, we're all kind of wondering this, but that will help us continue this work, thinking about local partners, thinking about the larger ties to other types of policies and broader structural factors, really thinking about what's already being done and where we can plug in to help policymakers and practitioners, and then thinking about engaging communities, policymakers, and what is most helpful for translation. Okay, so I will end there and just acknowledge a lot of people that have worked on this, these efforts and funding sources. Thank you.
So much. Unfortunately, we are out of time for questions because there is a class coming in right now and they need to set it up. But or you can come by and ask questions to Dr. Madrigano as we exit. And for those of you online also, we'll be uploading the talk to our channel. Please remember to sign up for our newsletter. Tomorrow we have a webinar by Dr. Horacio Riojas from in Mexico. And remember that April 8th, we'll have our next invited speaker, Dr. Casey Arms, from the University of Arizona, who'll be talking about climate change and infectious diseases. And then we'll also have the April webinar by Stephanie Ebel. And then the May webinar will be by Daniel Bush from Basel. So lots of activities. Go to our website for more information. And thanks again to Dr. Madrigano for what.
Thank you.